Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Dr. Alyssa Lanzi, an assistant professor in the Department of Communication Sciences and Disorders at the University of Delaware, and is on the executive committee for the Delaware Center for Cognitive Aging Research at the College of Health Sciences. Welcome, Alyssa. I'm so glad to have you here today. Can you get us started by just telling us a little bit about yourself?
Great. Well, thank you so much for having me, Sarah. I'm excited to kind of have the next 40 or so minutes having a conversation with you. And I'm really excited because most of my focus is on clinical translational research. And I started this field wanting to be a clinician working in clinical practice. And although I'm a researcher now, I really think I lean in first with my clinical lens and find that clinically translatable research is what's key. So I started at Duquesne University, getting my bachelor's and master's in speech language pathology with the goal of becoming a clinician. But I had the opportunity early on at Duquesne to work with a researcher in the adult neurogenic disorders clinic. And I really just fell in love with adult neurogenics and working with aphasia groups. So most of my clinical training has been in group life participation approaches in the area of aphasia. And I love that. I love the functional nature of it. I love the person-centered approach to care. And while at Duquesne, I had the opportunity to kind of expand those services to work with mild cognitive impairment. So those older adults who are at risk for dementia. And I was really kind of a key player early on in figuring out what SLPs can do with this population. And I really fell in love with that. And I did a master's thesis kind of investigating a group approach based on what I learned from the aphasia clinical world and traumatic brain injury. And I really loved research, and that led me to pursue a PhD with Michelle Bourgeois at the University of South Florida, who really is kind of the founding grandmother in many ways of speech language pathologists' role in dementia care. But I really was interested in this early onset and life participation and mild approaches. So we were able to work together, and I learned so much from her and what we can do to help older adults maintain their independence and live independently for as long as possible. But where I felt constantly kind of stuck while at USF was that we are only one piece of the puzzle as speech language pathologists in dementia care. And I felt to really help SLPs become key players in this, that I needed to learn interdisciplinary approaches and work with other kind of key players of dementia care. So I went to the University of Delaware to do a postdoc with Matt Cohen, who's a neuropsychologist, to really learn about MCI from the assessment diagnostic lens, to then think about, well, what can we do for treatment? And that was 5 years ago. And since then, we've grown quite a bit and have formed the Delaware Center for Cognitive Aging Research, which is a team of interdisciplinary researchers really focusing on addressing the needs of those at risk for dementia through education, through assessment, and through treatment approaches that are focused on lifestyle interventions, with SLPs really being a key player on the team.
Wow, that is an incredible career so far. I have to say personally, I've learned from you. I love following what you're up to. I think it's so cool that the life participation approach pulled you in, and then now you're using it in new ways. I'm so excited about our conversation today, and
you have such a wealth of knowledge that I thought we would talk about a sticky situation that a lot of clinical SLPs have dealt with. So this might not have like a super straightforward answer, and I think you're just the person to talk to about it. The topic today is around word finding challenges in clients who don't have that primary language disorder diagnosis. So I'm thinking about situations with a client who's aging and then they're reporting things like, I'm losing my train of thought, or like the words on the tip of my tongue, but they don't have like the stroke-based aphasia. And then like, what are we supposed to do as SLPs in that moment? Maybe they're even functioning at a high level with a diagnosis like multiple sclerosis. And what I want to talk about is with these type of clients, when the complaint is a little bit more vague, it's tricky to address, and it's tricky to know how to set goals and what to do exactly. So are you up for having that conversation today?
I will do my best, but as you mentioned, there is definitely no perfect answer. So I'm hoping we can kind of help clear out a really muddy area together, to kind of lead future research and clinical collaborations. But there's definitely no straightforward answer here.
Good. Let's kind of just talk about how we can better think about this or sort this out in the different clinical settings that we work with. So as we start, do you have any ideas or thoughts about like how we can organize our thoughts as a client gives us complaints like this?
Yeah. I was so happy that you asked in this question and wanted the podcast to be about this topic, because I think it pushes me even further as a researcher to think about what are the struggles that clinicians are facing? What are the things that they are hearing from clients? And how can we work backwards and think about how the research kind of matches what the clinical need is? So something that I hear a lot and that you mentioned is, well, I have this client with me. There's something going on underneath that's neurodegenerative of sorts, and they're losing their train of thought. They're having trouble with some language problems, but it's not aphasia, so what is it? What's going on? So I think to help us brainstorm this, we need to start by defining some terms that are commonly misused in our field and other fields as well. And there's a number of reasons why that is. And I don't want to spend time pointing blame at who that is, but I just want to make sure that we're kind of just on the same page, so that when we use these terms moving forward, we can just make sure that we understand the difference between some commonly misused terms.
Perfect.
So the two terms that I want to start off by talking about are terms that we use to describe the clinical syndrome that people experience. And when I think about this, I think about these are terms that we are used to describe symptoms, right? To describe symptoms. So mild neurocognitive disorder and major neurocognitive disorder are terms used to describe symptoms from a medical diagnosis, right? They themselves aren't the medical diagnosis, but they're describing the symptoms that one experiences from them, okay? And examples of medical disorders that lead to these clinical syndromes would be Alzheimer's disease, Lewy body disease, MS, right? Those are these neurodegenerative medical diseases that lead to these clinical syndromes. But there's also non-degenerative causes as well, such as stroke or traumatic brain injury. So it gets really messy. So first and foremost, when we're talking about kind of the experience that these folks may be having, we want to make sure that we're being clear. Are we talking about the medical disease, or are we talking about the clinical syndrome? And for us as speech language pathologists, we talk a lot about the clinical syndrome, right? Because we treat the symptoms experienced by medical diseases. So for mild and major neurocognitive disorder, there's specific criteria that one needs to meet, as described in the DSM-5, to be diagnosed with this clinical syndrome, and that there needs to be a modest decline from a previous level of functioning in cognitive abilities. This decline is not explained by a psychiatric illness and does not occur in the context of delirium. But the key distinguishing factor between mild and major neurocognitive disorder is one's ability to complete activities of daily living independently, right? Or one's functional independence. And that people who meet criteria for major neurocognitive disorder are no longer able to complete these activities of daily living independently. And when we think about this clinical syndrome, especially when the underlying pathology is neurodegenerative, so because of Alzheimer's disease, or because of Lewy body disease, or because of frontotemporal disease, what gets really tricky is then figuring out, well, then what's a modest decline in cognitive abilities? And how do we even begin to discuss when it is a decline, what is normal for an 80-year-old, what's normal for a 90-year-old, and what is even modest? So I'm hoping that that's what we can kind of think through together, some ideas that I have based on research and that I know clinicians are using to help us really figure out, well, then what is modest and what's a decline, if those are the distinguishing kind of features of what makes somebody have the clinical syndrome of mild or major neurocognitive disorder.
Fantastic. And I think already what I'm like taking from that is it's okay if maybe we don't have that like end etiology. It's not like figured out, but as the speech pathologist, we can still describe those symptoms, and using the term like mild neurocognitive disorder is appropriate. That's like within our scope to talk about that. So let's then think about aging and what we'll call like normal language changes that individuals can experience as they age. What types of comments from a client would you see as kind of that red flag where you're thinking, oh, okay, now we're crossing over, like this isn't normal and I need to do a little bit more investigating here?
Yeah. So the key is to identify those who are at risk for dementia as early as possible. That's really the goal, is can we identify those as early as possible so we can help intervene, right, and manage the clinical syndrome as early as possible. But to do that, then we need to determine if they have a level of decline that's not normal. And that's really challenging because all older adults, even typically functioning adults, experience memory hiccups, right? We've all walked into a room before and said, why did I go in here? Right? Or you are in a conversation with somebody trying to talk about a show that you were watching last night and you can't think of the name of the actor in the show. So we all experience these memory hiccups, but what's challenging is even in people who are typically functioning, these hiccups increase as we age. So a level of decline in language and memory abilities is typical. So then it really leads us to say, well, then how can we determine what's normal or not? And when I talk about this to older adults, I say it's really hard for us clinicians to do this because there is no gold standard for aging development. We have these gold standards in the field of speech language pathology for speech and language development, right? Like we have this milestone chart of when we expect articulation for an 8-year-old to be different than a 6-year-old. But we don't have this necessarily for older adults. And this is why it's really important that we use measures that are as sensitive as possible to determine early cognitive decline, and that we use tests that have normative data that can be used for somebody who looks like that person in front of you, right? So that we can determine, are those memory hiccups that this person is experiencing, are those hiccups appropriate for an 80-year-old? Or is that possibly indicative of something else going on? And that's why using norm reference tools that have good evidence for sensitivity of detecting mild impairments is really key. But it's hard, and we don't have that many tools to be able to do that. And this is where clinical interviewing is essential. And there are starting to become more and more tools that are designed to support clinicians in conducting an interview with their clients to determine whether their language or thinking changes are typical or not. Okay. So here are some conversations that I often have with clients, or here are some of those kind of red flag things that you mentioned before. So most older adults, when you talk to them, will say that they have word finding difficulties.
Right.
Almost any person that I've ever worked with, the first thing that they say to me is that the words on their tip of their tongue, and that's happening more and more. Okay. So what I want to then ask to probe further is say, well, what do you do when that happens, right? What are some things that you do? Are you able to pick back up in the conversation, or do you lose your train of thought completely and you can't go back? Okay. So how often is it happening? What are you doing when it happens? And how do you kind of bounce back from it happening? And if the client is saying that they're really starting to have more and more trouble bouncing back, or that the word doesn't come to them later on when they're laying in bed, that's when I may start to have a few more concerns. Okay. Or if I have a client saying that they're struggling with vocabulary of familiar items. So they're struggling to say the word clock or chair or table, or a person that they often talk to, they're struggling to recall their name or to determine what the meaning is of that word. I may say table, but could they point to the table? That then I'm having a few more concerns. Or if they're having trouble finishing their sentences, they're not participating in group conversations as much as they used to. They're using words with less meaning. So their conversations are becoming more full, there's not a lot of content in them. So they're saying things, but they're losing that content. They're having trouble, and that's happening more and more and more. So those probing questions can be really helpful, because with Alzheimer's disease, we expect somebody who has mild neurocognitive disorder to have empty speech, right? And we want to figure out a bit more, what do we mean by empty speech? How often are they experiencing that? And that's really where a clinical interview is key.
That's great. I think I'm like hearing you say, so if you're doing those questions and you're not getting those red flags, then that might be someone where you decide not to do like a ton of more in-depth testing, and maybe just providing education about what a normal aging process is like. And then if you do decide to go into testing where you're like, okay, we need to dig into this further, what type of tools or tasks do you see being helpful for the clinical SLP? I know you mentioned like those norm reference tests. Like, can you give us an example of what types of tests we could consider using?
Yeah, absolutely. And the other thing I want to mention before I even go in is, because if we're concerned about somebody's language, right, or their speech, we need to make sure first that their hearing is within functional limits as well. And there's really great evidence now to suggest that hearing is the single most modifiable risk factor for dementia. It attributes to up to 8% of modifiable dementia cases. So really, when we're talking to older adults and they're complaining of word finding challenges or challenges participating in a conversation or communication, we need to make sure first and foremost that their hearing is within functional limits and that they're using appropriate accommodations before even testing. So making sure that their hearing aids are on and working, or that you're using a pocket talker, that you're not covering your mouth, because hearing is without hearing that's in functional limits, you're not going to be able to kind of test further for these speech and language or cognitive differences.
Honestly, it's one of the best things to find out too, because it's like such an easy,
Yes.
it's like, yes, it was just your hearing. Good.
Exactly.
Yeah, so that's a great reminder.
Yeah. And the other piece that you said that is really important to emphasize is the education piece. There's there's a lot of stigmas associated with dementia. People are uncomfortable talking about it necessarily, right? Don't pick me. I don't want to talk about it because what if by disclosing these challenges that somebody's going to diagnose me? And that's where education is really key. So regardless of what you find in your assessment, providing education, describing the difference between clinical syndromes and medical diagnoses, describing that we all experience memory hiccups, this education is really key. And it's key for societal differences as well, not even just individual, but we need to start transforming how we're describing and even talking about typical aging as well. So, but back to your question, which was about assessment, it depends on what you think the possible medical diagnosis could be, what's the cause possibly of these language challenges that these individuals are experiencing. So it's really hard to answer this question without knowing what the person is in front of you, and it really should be person-centered for that individual and for the specific purpose of why you're doing the assessment. But here are some useful tools that can be helpful in figuring out, is this level of thinking and language differences, is this typical for an 80-year-old or not? So as you mentioned, and our highlight of what I said is that norm reference tests are really important. And this is where I really lean on the field of neuropsychology to help us in this. So tests like the Hopkins Verbal Learning Test, the Wechsler Memory Scale, these normative reference tests of episodic memory and verbal fluency like the COAT, these are going to be really great tests to tax the thinking and language system in a way that's not necessarily going to be fun for the patient. I always say these are designed to be hard. These are designed to be challenging. But it allows us to figure out if their level of decline in these memory or language abilities, is this typical or not? And then we can kind of use the norm reference data, making sure that we're using norms that are age, education, race, and ethnicity matched for that person in front of you. And that's easier to do in memory. It's a bit more difficult to do in language, right? Because we don't exactly have language norms, which is what's tricky. So then, as I can tell from Sarah's face, she's like, well, so what then? This is the problem, is language. So here are some things that have helped me. One thing I mentioned earlier is the importance of a clinical interview, and that there are starting to become more and more tools available that help us kind of structure and conduct our interview in a standardized but person-centered format. So the Assessment of Cognitive Complaints Toolkit for Alzheimer's disease, the ACT-AD, was developed and is used in California by all of their Alzheimer's disease centers. And it is really great at providing clinicians with prompts of how to ask these types of questions. And then what it does is then code kind of commonly given responses by patients and say, here's a response that may be a red flag, right? Here's a response that's typical. Here's a response that maybe suggests that it's not Alzheimer's disease pathology. It could be something else going on. So I really like that tool because it gives you kind of these standardized prompts and also gives you an idea of what are these responses, right, that we're looking for. Another tool that's like that, yeah, it really is amazing, and it's super user friendly. It's color coded. I think it's just really well done, and we need more things like this in the field of speech language pathology. This structured, person-centered approach. The Clinical Dementia Rating Scale, the CDR, this is what's most widely used as a staging instrument of one's functional status. It's used well outside of the field of speech language pathology. It's really used to help characterize the domains of cognitive and functioning that a person may be experiencing. But what I like about it and why I'm bringing it up is it does have a 10-hour free training that's anybody can do. And it's really great, once again, to listen to these videos and to do the training to figure out what level of decline is typical or what may warrant, what may I be concerned about, what's questionable, or what is clearly a response that this person's no longer independent anymore. So that training guide can be really helpful. So those two tools can be great for kind of a structured person-centered interview. But we can do, of course, way more than that as SLPs in language. So I think doing discourse analysis can be really helpful, and collecting discourse samples with older adults can give us a lot more insight into these language breakdowns in kind of tasks that are more ecologically valid, right? Or more reflective of everyday skills. So we on Dementia Bank have a discourse battery that can be downloaded for free that people can go on to have pictures and stimuli to elicit discourse in a standardized way. And then you could look at their connected speech and language and say, where are these breakdowns going on? And patient-reported outcome measures can help with that as well. So measures like the everyday cognition and the neuroqual, those can be really good ways to get more insight into how that person thinks their language and thinking abilities are in everyday life as well.
Just going to pop in here for everybody listening and say, we will link these in the handout because you're giving us some gold here and we want to make it easy for people to find. So they will be on the handout, which will be great. Okay, next question. I love to just hear how you're talking about this because as you mentioned, how we're providing education needs to be, revised, amped up a little bit. And so I really appreciate just hearing your actual words that you're using. So what kind of clinical terms are you using to describe when you see language changes related to aging? As SLPs, we're super familiar with using the word aphasia to describe those language changes after stroke or brain injury. Sometimes I've noticed just so far in my career, there's like confusion or disagreement about if we also use the word aphasia for those language changes that are not normal part of aging. So I just wanted to hear your thoughts about that.
Yeah. So this is kind of the elephant in the room that we've yet to talk about is, are we talking about language? Are we talking about cognition? Where does language fall? And I'm going to go back to my point earlier of terminology, and defining the terms that we use is really important. So as I said earlier, we have these clinical syndromes, and what these clinical syndromes are is they're describing the symptoms that one is experiencing from a medical disease. So for these symptoms, for somebody to have mild neurocognitive disorder, they need to have a modest decline in a previous level of functioning in cognitive abilities. And in parentheses in the DSM-5, in the cognitive abilities, it says it can be memory and or language. It also says executive functions, visual spatial, behavior, right? So it's a common misconception that when we're talking about mild cognitive impairment, that we're talking about memory only, and we're not. And we need to do a much better job in the field as clinicians and as researchers by specifying which domain of cognition are we talking about if we have that information, okay? And the terminology that we use is we kind of use further subtyping to describe these clinical syndromes. This further subtyping is mostly used in research setting, unless you're in a really specialty clinical care setting. But I think it's really important for clinicians to know about, because it helps us, once again, better describe the symptoms that the person is experiencing. Okay, so let's say we have somebody who has mild neurocognitive disorder. Let's say we have that person's diagnosis on our caseload. So all we know is that they have a modest decline in cognitive abilities. What we don't know is which cognitive ability, right, necessarily. And the other thing we don't know is what's the underlying pathology as well. So what we can say, what terms we can use are amnestic or non-amnestic mild cognitive impairment. Amnestic's describing if the primary impairments are in memory, Non-amnestic is if the primary impairments are in another domain other than memory. And then further on, we can say, is it amnestic single domain or amnestic multi-domain, meaning how many cognitive domains are at play? Because that's the thing. It often is memory and language, right? Or language and executive functions. So even just by simplifying and just being more specific of what domain we're talking about can really help us. The other piece that you bring up that I want to highlight is this idea of, well, what if it is language predominantly and language first, meaning that language is the first symptom that one experiences and the predominant symptom as well. And that's when we get into the term primary progressive aphasia. And primary progressive aphasia is describing a clinical syndrome. It's not describing a medical diagnosis. And all we're saying is that when one has primary progressive aphasia, they're having a modest decline from a previous level of functioning in predominantly speech and or language. Okay, so that's kind of the key distinction between these two, is with amnestic mild cognitive impairment, the predominant impairments in memory, and primary progressive aphasia, it's language and or speech. But once again, still with those clinical terms, we don't know the underlying pathology. And for primary progressive aphasia, it is mostly frontotemporal disease, but it could also be Alzheimer's disease as well. So it's really important that we don't assume, all right? And we just are okay with having these conversations and saying, I'm not sure, right? And asking the questions to help us figure out what is it going on if we're fortunate enough to know it all.
I hear you giving us a lot of permission with being kind of in the messy middle. That happens a lot with this. So I just really appreciate you explaining that. Thank you. Can we talk about treatment then and what treatment ends up looking like? So we've gone through the assessment and, good history and interview process. When we discover that someone is having those language changes that are not considered normal, what are the evidence-based treatment categories or types that we're thinking about? Just wanting you to give us an overview, like what's the recent research say, and what are some of like the takeaways we should have in mind from the research?
Yeah. So when we're thinking about treatment for language challenges that one's experiencing early on, so kind of these mild language challenges, the goal is to help them maintain their functioning for as long as possible, right? So to help them repair their language or learn strategies to better participate in functioning, to better participate in everyday life. And what the evidence is telling us now is that language could be a potential biomarker. So language could be a potential way that we identify early on if somebody's at risk. That's so exciting and is going to be huge for the field of speech language pathology if we can start to use language as a non-invasive biomarker to detect dementia from Alzheimer's disease. But what's scary is we're not yet there with the treatments yet, right? So we're starting to look at language as a possible biomarker and an early identifier, but we're not yet there with treatment. So I'm going to lean here on my colleagues in the primary progressive aphasia world because they really have the best approaches for addressing language when the underlying pathology is neurodegenerative. So Maya Henry's lab and Stephanie Grasso in Texas, they're doing really amazing work in helping us think about restorative approaches early on. So even though it is neurodegenerative, there is evidence to suggest that we can do these more kind of intensive restorative treatments early on to help them kind of maintain their language abilities. So they're using approaches like the video implemented script training for aphasia. And that's a really cool approach that you actually watch somebody's lips move and practice moving your lips as they're moving their lips to better communicate a script that's meaningful to you and to that person. The goal is to figure out what's meaningful to them, right? And tailor it to their individual needs. You're also starting to see some researchers and evidence-based approaches to kind of modifying the principles of semantic feature analysis right, that we use in the aphasia world a bit to kind of support the lexical retrieval challenges that individuals with primary progressive aphasia are experiencing as well. So those are kind of like our restorative early on approaches. And then there's also, of course, compensatory approaches. So Melanie Friedoken and their group is doing some wonderful work of, well, how can we use AAC, unaided and aided approaches to kind of make personalized communication boards, right? To help people better participate in meaningful activities. And what I want to say with this one is your language abilities don't have to be so far progressed that you have to rely on these things to treat them. Right? We want to treat them early on and customize them with the person so that they can be comfortable using them before they even have to rely on them necessarily. And then that kind of last approach with primary progressive aphasia and what the evidence is telling us is to treat the environment, right? And to work with communication partners. So modifying approaches that are used for like communication partner training, and using those for primary progressive aphasia. So having videos, having feedback, and making sure the environment is conducive to their communication. But even though I just presented that approach, like it's linear, like restorative, compensatory, then environmental, what I want to say is it shouldn't be that way. We should be thinking about environmental from the start. We should be thinking about the possible progression of these abilities from the start and having those difficult conversations early on so that they're as empowered and as prepared for the future as they possibly can be. That's the benefit of early identification and early treatment, is so that we can provide them with the resources and the education while their abilities are still relatively intact.
Wonderful. You gave us such a great summary of the different things to think about. And I just wanted to tag on to the AAC comment. That's something I've gotten a lot better at doing since I've been into the life participation approach, is just understanding, like, yeah, you're not waiting until the moment someone needs AAC. And I've been trying to use different language with my clients where if we're making some type of like word bank or communication book, I'm calling it like a database for them, where it's like, you're not necessarily using this all the time, but if you get stuck, just check your database. We have all of those words like organized for you. And some of my recent clients have really liked that. I think it just helps them understand it in a different way.
Yeah, I love that. I love that database idea. And Jamie Riley and their group is doing a lot of that. Like, what's your inventory? What's in your database? What's personally relevant for you? And it's such a great way to frame it and to talk about it as well.
Yeah. People really tend to understand that. So, talking about kind of that compensatory mindset, I know a lot of the work we do is strategy based. You and I have worked together before, and I really like how you helped us think about strategies. Like, we're thinking about before the word finding issue, like in advance. We're talking about during the word finding issue moment and after the word finding issue moment. So I don't know if you wanted to say any more about that, or kind of like how you work with clients to think about those moments. Do you have anything to share on that?
Yeah, so most of my work is in the research world and investigating kind of a compensatory cognitive treatment for those with amnestic mild cognitive impairment. So those who have memory impairments mostly. However, it's not just memory, right? A lot of these clients have memory and language impairment. So that kind of amnestic multi-domain. And a lot of times a common goal that we're working with these clients is, let's say they want to better communicate with their doctor, right? Super meaningful, easy to bill for, right? We want to support their communication with their doctor. So what I want to help them do is, in a non-stress environment, first prepare for what conversations you may be having with your doctor before you even get there, right? Let's write out what are all the things that you would possibly talk about. As you come up with the question, write it down immediately, right? In your calendar slot for that doctor's appointment. You see this new drug on a commercial, or your friend talks to you about this new drug. You want to see if it's applicable to you. Well, write it down immediately. Write it down in the same place, right? Think about, prepare in advance in a non-stressful environment for what are those topics you're going to want to talk about. What are the things that are important to you, right? So trying to prepare, it's kind of the time pressure management approach that we do in the TVI world, kind of adapting it for that in some ways. Then in the moment, we want to teach strategies to help the person be successful. So let's say they're talking to the doctor and they experience a word finding, right? They get stuck in the conversation. So what you want to teach them is immediate repair strategies. And it should be based on that person and their cognitive strengths and weaknesses and their personal approach as well. So do you want to teach them to immediately go to their calendar invite, right? Because remember, that notes section is going to have all the word finding that they need. Or do you want to teach them some type of internal strategy, like the alphabet strategy, to kind of do a scan to help them do that letter? Or are they somebody who can really do strong circumlocution strategies or semantic feature, right, to kind of cue them? And that's what you're working on in therapy, to figure out, like, what is that breakdown in the moment? And then after, what you want to do is have really strong rapport with your clients. And this is where a group approach can be really beneficial, so that they're comfortable reporting back and sharing not only what went well, but what didn't go well. So we can brainstorm together why it didn't go well. So they got really stuck with their conversation and they weren't able to repair it. Well, why was that, right? And you don't give them concrete feedback per se. You guide their discovery of the feedback. You help support them, and in a group approach, they can even kind of support each other in that way. So that's one way that, we're not working on language per se, but these memory strategies that we're working on, these external memory aids, are used to support their communication, which in turn then supports their language as well.
Awesome. I love the example you shared, and just the overall idea that our role is really so much more than just like having a list of strategies and just like, here, I'm passing off the list to you, right? It's like our therapeutic role is identifying the key, like one or two strategies that is most helpful for the client. And your example like showed that perfectly. So thank you. That's great. I did have a question about the care partner situation, which, as you mentioned, we're not just doing this alone. We're part of like a big hub of people. So often in the aging process, the other stakeholders, their care partners, or even the other professionals that are involved in their care, it's so important for their success and in life participation. I just wanted to know if you had any tips with the work that you've done for like talking points or things that just help establish a great working relationship with the care partner for like buy-in and carryover, that type of thing.
Yeah, it's hard. It is hard. And I want to acknowledge that first, right? We only have so much time to work with the client, and then that's not even the full picture, right? You can't work with a client without considering all of their care partners as well. So I think one thing that's really important is to provide education to that care partner, regardless of what you decide. If you decide to include them or not, but provide them education on why you made that decision. Why are they included in the therapy session, or why are they not included in that therapy session? So for context, I run a clinical trial right now that's on this compensatory treatment that I talked to you about with folks with mild impairments. And I don't include the care partners, and I don't intentionally, because I want it to be for those to independently use these strategies. But a big piece of it is I want them to advocate for themselves and educate their caregivers. I don't want to be the one to do it. I want them to be empowered to do it as well. So that's really important. That's really important that they know that explicitly and that they know it's their role, right, and responsibility. And there's a lot of benefits of including them as well. Of course, especially when the underlying pathology is progressive, we need to make sure we include them also. So regardless of what you decide, there is no clear evidence that one approach is best or not, is to provide education and acknowledge that this care partner is stressed right? And managing their stress is first and foremost. And to acknowledge that the education you provide in the session is not a single time point. You need to provide education multiple times and give them resources to look beyond this session to get that education. And the National Institute on Aging and the Alzheimer's Association have so many printable resources and free resources, like a 24/7 hotline. And these resources need to be given to the caregivers. Even if they don't need it now, they may need it later as well.
Awesome. Thank you so much. This has been such a good discussion. I'm absorbing so many awesome tidbits that you've shared with us. Talking maximum impact from our discussion today, what would be your top 3 actionable takeaways for clinicians to put into practice?
I think the top 3 is 1, to really value the importance of education and how it's well within our scope of practice as speech language pathologists to provide education, and that there is no clear healthcare provider whose role it is to provide that education, and the general public's knowledge of neurodegenerative causes of MCI and dementia is poor. So it's well within our scope of practice, and we need to provide education. It's key. I think the second takeaway is the importance of advocacy for why early identification is so key, and that we want people to be set up for success as best as possible. And a really cool study came out that actually showed that clinicians are often more nervous than the patients are to identify somebody early on, and that it's really important, and we need to make sure our own bias is not getting in the way of making sure that we're providing early identification and advocating for our role in early identification. And then the last takeaway is something that you said, Sarah, that I just wanted to comment on, is that, a worksheet is not our scope of practice, right? Giving someone a worksheet, anyone can do that. And that we are skilled healthcare providers. And in the terms of COG rehab, that really means like tailoring a strategy with an evidence-based approach and education and personalizing it to them. So if it feels a bit like it's putting the pieces of the puzzle together, that is how it should feel like. And it's our job to provide the education, the evidence-based instruction, strategy, and personalization, and be kind of the puzzle master or the puzzle leader in some ways.
I love that. That is wise. I love that you're encouraging us to continue to be a key player in this discussion and in the care for these clients. Thank you so much. To wrap things up today, what final words of wisdom or inspiration would you like to leave with the audience?
Yeah. I think that SLPs have really unique expertise that make us key players in dementia care, and that we have value in helping people reduce their risk of dementia and better manage dementia care. And that you don't have to be a researcher to be involved in research, and that we as researchers also rely on the frontline clinicians to help refer to studies that for clients that you see, and that if you don't feel that you can do this treatment, there may be a research study out there for you. So also don't feel that you have to be a researcher to get involved and be research, and that we rely on those in the front lines to help identify folks who may be a good fit for our studies, but also to figure out what are your needs in the clinical care as well.
Thank you so much, Alyssa.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform, and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.